Endometriosis impacts between 20 to 70% of women who have trouble conceiving. This is a complicated syndrome, and there's a lot of disagreement on the best way to diagnose and treat it.
Today, we'll be joined by the foremost experts on the subject, and we'll delve into how to identify and treat endometriosis with the goals of conceiving and reducing pain.
My name is David Adamson. I'm a reproductive endocrinologist and surgeon and a clinical professor on the adjunct clinical faculty at Stanford University, past president of American Society for Reproductive Medicine. Today we're going to talk about endometriosis, a really difficult disease, but we're going to talk about how you can diagnose it and how we can treat it and how we can help you with problems with infertility or pain or other difficulties that endometriosis is causing you.
I'm Carlos Simon. I am a professor at the University of Valencia, Spain, and adjunct professor at the Stanford University, as well as scientific director of Genomics.
I'm going to tell you the important things that you need to know about endometriosis.
Effectively, endometriosis occurs when the cells that line the inside of the uterus escape out of the uterus, causing all sorts of damage and inflammation.
These cells feed off of estrogen to grow, which is important to remember when we come back to discussing treatments that help reduce its negative impact on fertility.
There's reason to believe endometriosis harms fertility and in a variety of ways.
To summarize how natural fertility works and how endometriosis can develop, here's David Adamson, who's on faculty at Stanford, is the president of the World Endometriosis Research Foundation, and a past president of ASRM.
For women who want to have a baby, it's important to know what some of the basics are that are necessary in order to get pregnant and carry that baby. So this is a diagram of a uterus, and we can see the walls of the uterus here, and this is the uterine cavity in here. We can see the ovary here with a fallopian tube, and another ovary over here with the other fallopian tube. So what normally happens is that each month, the hormones that come from the brain help a number of follicles develop in the ovary. And out of these follicles developing, one of them gets quite big, and then it ovulates an egg. And this egg gets picked up by the fallopian tube. This fallopian tube can move around, and it picks up this egg, and the egg ends up in here in the distal part of the fallopian tube. When the couple are wanting to get pregnant, they have intercourse, and sperm come up from the vagina and the cervix and into the uterus, and we have thousands and thousands of sperm that make it this far and keep going up until they reach this part of the fallopian tube where the egg is. So many people don't realize that fertilization, the beginning of life, actually happens out here in the end of the fallopian tube when the single sperm enters the single egg. And then what happens is this egg starts to divide, the cells get bigger, and by day three, we have about 8 cells in this little embryo, and it's called the cleavage stage embryo. And the embryo is moving back and forth in the fallopian tube and the fluids as it develops. By day 5, this embryo finally moves out of the fallopian tube into the uterus. And at this point, it's called a blastocyst. It's spelled like this, blastocyst. And it has somewhere around 150 to 250 cells that have already started dividing into cells that are going to make the baby and other cells that are going to make the placenta. Now, while all of this has been going on, the hormones that were working to help with the development of the egg have also been developing the lining of the uterus. And the lining of the uterus is called the endometrium. And so this type of tissue is hormone dependent, which means it responds to estrogen and progesterone. So the estrogen makes this lining, the endometrium, grow, and the tissue gets very, very thick. And so there's estrogen to make it grow in the first place. And then after ovulation, progesterone comes along, and progesterone helps to stabilize and mature the endometrium and make it receptive for this blastocyst. So actually about a week, 5, 6, 7 days after ovulation, this blastocyst is going to implant in the endometrium. and then it will continue to grow. The placenta develops, and about 8.5 months later, the baby will get delivered if all things go well. With endometriosis, the disease that has a genetic basis and many other factors, we know that the endometrium here doesn't work entirely normally. So the first problem is that the endometrium may not be receptive for this blastocyst to implant. It's not quite right. And so this can cause infertility. Even more than that, every month as the endometrium gets bigger, if the woman doesn't get pregnant, the endometrium comes away 2 weeks later because the estrogen and the progesterone drop off, and the endometrium comes away as the menstrual flow or the period. Now, what happens in endometriosis is that this endometrium is not normal, and some other abnormal things happen that cause this tissue to come out through the fallopian tubes into the pelvis. And so this tissue that should be in here is abnormal, and it comes out through the tubes and it implants. It implants here on the ovary, it implants on the peritoneum, which is the lining inside the pelvis, sort of like the skin inside, and it can implant on the bladder or the bowel. It can also implant on the fallopian tubes, and it can implant on the uterus. And so all over the place, you get endometriosis. This causes an inflammatory reaction, which makes an unhealthy environment inside the pelvis. And so this, we know, can interfere with the egg getting developed and matured in the ovary. With ovulation, it probably can interfere with the tube working. It interferes with sperm coming up the tube, can interfere with the fertilization occurring out here, and as already mentioned, can interfere with the blastocyst implanting when it gets back into the uterus. So in these and other ways, the endometriosis can cause infertility.
Endometriosis may be most damaging to fertility when it lands and embeds itself in the ovary. As you can see, patients with endometriosis often have lower antral follicle counts and AMH levels, which correlate with egg quantity.
There's also reason to believe that endometriosis not only reduces egg volume, but also egg quality. Eggs donated from women who had endometriosis to women without endometriosis often implant at lower rates.
However, and we published this in 94, if it's the donor that donates the egg, if the donor has endometriosis, the clinical results goes down abruptly, half of the results, half of the outcome that you will have.
So endometriosis in the ovary is extremely problematic from a fertility perspective. Where experts disagree is how much of a fertility issue endometriosis creates when it shows up elsewhere in the pelvis.